Hello and welcome to the topic Septic Arthritis in the Rheumatology module. By the end of this topic, you should be able to define septic arthritis, explain the causes and pathophysiology as well as the mode of acquiring this infection. You should also be able to describe the clinical features seen in septic arthritis, outline the investigations to support the diagnosis, discuss the principles of management, and finally elaborate the complications expected in septic arthritis if left untreated. Let's get started. So what is septic arthritis? The term septic refers to infected with microorganisms, especially harmful bacteria. Septic arthritis is also known as infectious arthritis. It is the invasion of a joint by an infectious agent resulting in inflammation and, if left untreated, destruction. The most common organism overall is Staphylococcus aureus. The most likely organism are Staphylococci and beta-hemolytic streptococci. In young adults who are sexually active, Neisseria gonorrhea should be also considered. The most likely organism to have been aspirated from the infected hip joint replacement prosthesis is propioniform bacteria acnes. Septic arthritis results from the introduction of pathogens into the joint space either directly or via the hematogenous route, which is the most common route. A pre-existing inflammation can lead to neovascularization of the joint space, which then leads to bacteremic spread from distant sites, and this then leads to increased adhesion factor expression in inflamed space. This follows with increased colonization of the synovial space with bacteria, which ends up with rapid bacterial growth. Septic arthritis through hematogenous spread can be the result of bacterial migration from a distant site, for example, an abscess and wounds or septicemia. It can also be due to the disseminated infection, for example, following gonorrhea. When septic arthritis is caused by direct inoculation, it can be the result of iatrogenic procedures such as joint infections, joint arthrocentesis, arthroscopy, and traumatic injuries such as infected wounds around the joint and penetrating injuries from foreign objects. Septic arthritis is one of the important differentials for a red, hot, and swollen joint. As it is infective in origin, those affected will often present with a fever and a joint which is erythematous, hot, swollen, and painful with marked reduced range of motion. Usually, only a single joint is affected. Any joint can also be affected, with knee being the most common. We have the cautious criteria for diagnosis of septic arthritis, which involves fever of 38 degrees Celsius and more, non-weight-bearing joints, as well as raised inflammatory markers, which are erythrocyte sedimentation rate and the white cell count. There should be a high index of suspicion of septic arthritis in a patient who presents with an acutely hot, swollen, and tender joint. Joint aspiration is done as the main mode of investigation to confirm diagnosis. It is done under sterile conditions to prevent introduction of infection. Infected joint fluid is typically yellow-green or turbid in appearance, demonstrating predominance in polymorphonuclear leukocytes. Synovial joint gram staining and culture is usually positive in 70% of cases, and can reveal pathogen with its respective antibiotic sensitivity. A negative synovial culture does not exclude septic arthritis. Of course, other investigations include blood cultures, ESR, and CRP. One has to always remember that septic arthritis is a joint-threatening and life-threatening condition. The goals of therapy are to avoid progression of infection to systemic sepsis, preserve the joint function, and prevent complications. Infection of a native joint can be treated with joint aspiration and empirical antibiotics therapy. Intravenous antibiotics which cover gram-positive cocci are indicated. The BNF currently recommends flucloxacillin and clindamycin if penicillin allergy. Duration of antibiotic treatment is normally for several weeks, where BNF states between 6 to 12 weeks. Ideally, this should be intravenous for 2 weeks and then oral for 4 weeks. If gonococcal arthritis is suspected, then ceftriaxone is more suitable. Needle aspiration should be used to decompress the joint area, which is filled with fluid. This too can reduce pain and swelling. Surgical drainage may be needed if frequent needle aspiration is required or if it is an infected prosthesis. The complications associated with septic arthritis can be classified into localized or systemic. The most common complications are joint damage, which occurs in up to 50% of adults who develop septic arthritis, and this is due to damage to the articular cartilage caused by severe inflammation within the joint. Next would be osteomyelitis. If the joint infection is not well dealt with, then the infection may well spread into the surrounding bone, causing infection of the bone. An MRI scan will be useful in picking this up. Lastly, systemic complications which can arise is sepsis itself. If the bacteria that is colonizing the joint space reaches the bloodstream, this can lead to systemic sepsis. In summary, in septic arthritis, there's joint inflammation which can be caused by various bacterial infections which spread contiguously or hematogenously. The minority of the time, it's caused by Neisseria gonorrhoeae and it's called gonococcal arthritis. But the majority of the time, it's caused by Staphylococcus aureus or some other bacteria and it's called non-gonococcal arthritis. Diagnosis requires getting a joint aspirate and imaging, as well as treatment includes antibiotics and surgical management, which is arthrotomy washout once infection is confirmed. This is to prevent joint destruction. We have come to the end of this topic. Thank you.